Welcome to The Explainer. Today, we are breaking down enteric fever. We're going to cut through the noise and give you just the high-yield facts, the mnemonics, and the clinical pearls that you absolutely have to know to crush your exams. Let's dive in.
So here's our game plan. We'll start by unmasking the culprit, Salmonella. Then, we'll trace its path as it invades the body. After that, we'll get into the clinical signs, figure out how to prove our diagnosis in the lab, and finally, we'll cover how to fight back with treatment and prevention.
All right, first things first, let's get formally introduced to the villain of our story, the Salmonella bacterium. You've got to know your enemy to defeat it, right?
So, what exactly is enteric fever? Look, at its core, it's a systemic illness that can be fatal. And this is key. This isn't just some run-of-the-mill stomach bug. We're talking about specific Salmonella types that get into the bloodstream and cause trouble all over the body. Now, who are the usual suspects? You've got four main players to commit to memory. They're all gram-negative bacilli, but remember, Salmonella typhi is the big boss. It's the one that causes the classic, most severe disease we call typhoid fever.
Okay, this table right here, this is pure exam gold. It breaks down the three key antigens. Think of them like different flags on the bacteria. The O antigen is the body flag. It shows up early. The H antigen is the tail or flagellar flag. That one pops up later. For your practicals, the key takeaway is what the clumps look like. O is granular and chalky, H is big and fluffy. And that V antigen, think of that as its invisibility cloak. It signals virulence and tells you someone might be a chronic carrier.
So we've identified the bad guys, but how do they go from being in contaminated water to causing a full-blown systemic infection? Let's unpack the pathogenesis.
And to make this super easy to lock into your brain, we're going to use a simple, really effective mnemonic, IMBIB. This will help you walk through the entire process step by step, no problem.
Let's trace the path of invasion with our mnemonic IMBIB. It all starts with I for ingestion. From there, it gets into the gut and invades the M cells. Then it breaks out into the body and does something really clever. It hides inside our own macrophages. This leads to an initial, kind of quiet, bacteremia. Then the bacteria spread throughout the body, setting up shop in the liver and spleen. The final step is E for expression. This is the big one, a massive secondary bacteremia that finally unleashes all those classic symptoms.
So what does this whole invasion actually look like when you're at the bedside with a patient? Let's decode those classic clinical features that should make you think, this could be enteric fever.
And for the clinical picture, we've got another essential mnemonic for you, Step Rose. This one covers all the most high-yield signs and symptoms you'll see.
Now there are two signs here you absolutely cannot forget. S is for stepladder fever and R is for rose spots. That stepladder fever isn't random. It's happening because the bacteria are being released in waves from the liver and spleen, causing the temperature to climb up, up, up in stages. You combine that with those faint little rose spots on the trunk, a toxic appearance, abdominal pain, and organomegaly, well, enteric fever should be shooting to the top of your differential diagnosis list.
All right, time for some detective work. You've got your clinical suspicion, but how do you prove it in the lab? This is all about picking the right test at exactly the right time.
With enteric fever, timing is everything. Here's the rule. Week 1 is the bacteremic phase, so the bacteria are in the blood. That means blood culture is king. By weeks 2 and 3, the body's antibody response is in full swing, so that's when serology, like the Widal test, becomes useful. Then, by weeks 3 and 4, the bacteria are being shed from the body, so that's your chance to find them in stool and urine cultures.
So let me just say this again, because it's that important. If a patient walks in during that first week of fever, your gold standard test is a blood culture, period. It's got the highest yield by far. It'll be positive in about 90% of cases. But I can almost guarantee you're going to get asked about the Widal test. It's a classic for sure, but it comes with a lot of catches that you really need to understand.
Interpreting the Widal test is really just about pattern recognition. You're looking for antibody titers that are rising. The TU antibody tells you, hey, this is a recent infection. Then the H antibody tells you which specific serotype it is. So see a rise in TO plus TH. You're looking at S. Typhi. TO plus AH, that's S. Paratyphi A. It's that simple.
And when you're in your practical exams, you have to describe the agglutination reaction correctly. O agglutination gives you these dense, kind of chalky clumps. H agglutination, on the other hand, it's totally different. You get these big, loose, fluffy clumps that look like little bits of cotton. The appearance itself is a clue.
But here is the classic exam trap you have to avoid. The Widal test has major limitations. You can get false positives from things like a prior vaccination or even another infection. And you can easily get false negatives if you do the test too early or if the patient is already on antibiotics. So never, ever rely on it alone. Okay, we've nailed the diagnosis. Now what? Let's talk about how we treat the patient and how we prevent this thing from spreading. This is just as high yield as getting the diagnosis right. For treatment, your modern-day go-to drug is ceftriaxone. If you need a good oral option, azithromycin is a great alternative. Now here's a critical update for your exams. Due to massive resistance, drugs like ciprofloxacin are no longer a first-line choice. That's an old-school answer. And for those tricky chronic carriers, you're looking at a long 6-week course of high-dose ampicillin. And please, don't forget supportive care. Hydration and nutrition are absolutely key. Of course, the best way to win a fight is to avoid it altogether. Prevention really comes down to Public Health 101, clean water, safe food, and good old-fashioned hand washing. For people at high risk, like travelers heading to endemic areas, vaccination is your best bet. Public health is really the ultimate treatment here. All right, let's wrap this up. We're going to consolidate everything we've talked about into one final summary slide, perfect for that last-minute cram session right before your exam.
This is it, your final revision checklist. The absolute must-know facts. Agent, Salmonella typhi. Pathogenesis, it invades M cells and hides in macrophages. The key signs, stepladder fever and rose spots. Your gold standard diagnosis, blood culture in week 1. Drug of choice, ceftriaxone. And prevention, sanitation, and vaccines. You lock those in and you are going to be in fantastic shape.
So, let's end with this. A stepladder fever isn't just a random fact to memorize for a test. It's a chapter in your patient's story. Learning to read these clinical signs, to see the patterns,